told, standard precautions are mandatory these days. Not these days, any days they were mandatory. You have to wear the cap, gowns, gloves, even this time's double mask maybe, shoe covers and all protective eyewear has to be worn, and you have to protect yourself. And in some other countries, if they are not worn, you won't be even compensated if you contract any disease or die, because that is mandatory, and you may even not be allowed to come to a trauma bay if you are not using these standard precautions. So that is the first thing you do. So here you can see initial assessment, the things are done simultaneously. This is probably a big trauma center. So where each, you can see someone is looking at the airway, someone is listening to the chest and probably feeling pulses and looking at the pelvis. And so there are sort of multiple teams. So this is an example for horizontal reservation. So what is the quickest way to assess someone's airway and breathing? But here, of course, you can't apply to an intubated man. But of course, if you're not, the patient, assume he's not intubated, how you can assess the airway and breathing is by talking to the patient. So when you talk to the patient, it won't take you 10 seconds actually. So when you talk to the patient, you can have with fair certainty say that his airway is patent. If the patient has no patent airway, he won't be able to talk. If the patient talk back to you, then at least you know that his airway and airway and breathing is acceptable, and he should also have acceptable hemodynamic status. If he has very low blood pressure without perfusion of the brain, he won't be able to talk. And also, if there's no considerable neurological function of the brain, he won't be able to articulate and speak. So at least you know airway, breathing, circulation, and central nervous system is of certain function if the patient can talk back. So that is one of the quickest way you can assess a man who can talk. So, as you said, A, B, C, D of this man, if he can talk back, is of course satisfactory for the time being. It can change. So I told you about the SOP or standard operative procedure in most of, in military procedures or even in drills or whatever. The same thing happens here. But the patient may have different circumstances. You can see it's a pregnant lady here on the left and an old man on the right. You start with the similar A, B, C, D, E. So primary survey, you start with the airway. You have to, if the patient cannot talk properly, you have to clear the airway. That is the first thing you do, because airway is supposed to kill you the quickest way. How would, if I sort of choke someone else's airway, within how many minutes would you die? Half a minute, 1 minute? No, probably longer than that. So you can survive for about 5 to 10 minutes without an airway. From there onwards, of course, your saturation will start dropping, and then oxygenation will stop, and then to stop the organs first, and then wreck the organs. So you stop the organs as well as wreck the agents with hypoxia. So of course, if you behead someone, you can kill even faster, within seconds. So anyway, in a normal circumstances where most of the patients will be coming to you in this way, so you start with the airway. So how do you assess the airway? There's a lecture on the airway, but of course you talk to the patient, and then if the patient can't talk, or patient on a tube, it is if the patient is on an intubated endotracheal intubation, that means patient has a definitive airway. So the patient may be having totally normal airways as well as totally secured airways or intubation. So you may see the spectrum in between. So you need to address accordingly by using adjuncts, airway adjuncts as well as definitive airway methods. Okay, the next what you do is you assess the breathing. That means once the airway is patent, the oxygen has to go from air into the circulation. That means that the apparatus of the chest and the lungs. And of course, there has to be circulation in the lung as well. So to assess that, there are things that you need to do. So you need to check the trachea quickly, whether it's central or not. It's very important. And you can look at the chest movements. And of course, you can then palpate and see if there's any tender areas or crepitus, and then you can auscultate. So once you do that, you need to quickly assess if there's adequate breathing effort and if there's adequate air entry. So breathing effort is one thing, that is the patient has to have an intact nervous system as well as the musculoskeletal system, and of course the air entry through the airway, there should not be any impedance like pneumothorax or hemothorax to the circulation of air into the lungs. So anything that will affect this will cause, of course, the patient will have a high respiratory rate and reduce chest movements, reduce air entry, and of course, oxygen saturation will be low. So those are the cumulative outcomes in a patient who has compromised breathing plus or breathing and ventilation. So you need to address this life-threatening conditions of the chest, which, for example, pneumothorax, attention pneumothorax, a flail segment of the chest. That is, a flail is an instrument or a weapon that is used where that movements occurs in opposite direction. So it is some similar like that, similar to that. I think the breathing lecture will go on to details of this. So massive hemothorax as well as pulmonary contusion will kill patients due to lung problems, and also other thing is cardiac tamponade, where there's blood collection in the pericardium, as well as severe cardiac contusion can also kill a patient due to problems of we usually categorize into this region B. So we assess breathing and the other problem that I just mentioned during assessment of the B. Right. So the next would be ABC. Also, I would say you need to start high flow oxygen all the time. That is what I forgot to mention at the beginning of airway and breathing. The moment you clear the airway, you have to use 15 or higher liter rate of oxygen through a non-release breathing mask. So the patient has adequate oxygen delivered to him. This will help especially the patients who are compromised. Then comes after the A and B, then come the circulation. So circulation assessment is, of course, the patient is conscious. We can assume that he has acceptable level at least to perfuse the most important organs, that the brain, the heart itself, the kidneys and the lungs. So usually we take 90 blood pressure systolic as adequate amount, but that is for the primary survey duration only. Is okay, we can assume it's at least above 90 systolic. Skin color and temperature it may be in a fairer skin, but sometimes it's difficult to assess. You can't go over, but of course, a lot of things can change the skin color and temperature. But of course, if the skin is pale, especially the palms in our populations, and the patient is cold and pale in the conjunctiva, of course, you need to have very high suspicion that patient has bled. Other thing is, of course, pulse rate and the character. The rate will be very high if the patient has gone into we will be talking of classes of hemorrhage later, class 1, 2, 3, 4. If the patient is in class 4 hemorrhage, maybe patient may not have pulse at all. And sometimes only pulse that may be palpable with the carotid pulse. It will be very, very high rate, as well as what we call a 3D pulse. The pulse pressure will be very, very low. There are two aspects of attending to circulation. So one thing is, if injured patient is, I will always say, like the pail with holes. So how much you fill the pail with blood or saline or whatever, it's not going to stay in there because there are holes. So you need to plug the holes as well as fill the bucket. So filling the bucket is giving fluids and blood, and plugging the holes is the stopping the hemorrhage. There are lots of ways to stop hemorrhage. We'll be talking in the shock thing, but at least you need to know put direct pressure as well as use of judicious use of tourniquets are important. Sometimes these are for peripheral or limb extremities. Of course, like the dorsal injuries, you patient may need to go to theater to control bleeds. So when assessing blood pressure pulse, sometimes you need to be very careful because children behave, very, very small children behave in a different way to very elderly person. Because elderly people may be on several drugs which can control their pulse rate. Sometimes athletes, they can have their normal heart rate may be 40 and 100 may be a severe tachycardia for them. So you need to assess, be a bit careful on assessing blood pressure and pulse alone. So that is one thing that you have to keep in mind. Control of hemorrhage, as told, there are several ways of doing it, but you have to control hemorrhage while restoring volume. So restoring volume, you immediately put 2 wide bore cannulas, at least 16 gauge. That is gray color. Orange is 14, so you can use a white or gray, just 16. Best place is to put is the antecubital fossa, and I lost my picture. Let me see. Sanjay, can you explain? I don't know. My screen is shrunk.
Yeah, can you take your cursor? Yeah, can you take your cursor onto the? Okay, you can see it now, no?
I can see myself. I can't see the presentation. Let me see.
Still you can. Now see whether you can.
No, still it's a very small screen that I see.
Oh. Okay, then shall I move the slides? Sharing difficulty?
Right, okay. Right. Can you, shall I log in again or see what's... Yeah.
Or you want, shall I remove this thing so you can present your presentation? So once you finish, I'll use mine.
Wait a minute, this it's very, very small. It's like a size of a stamp that I can see. Okay. Wait, shall I allow? Okay. Now I can.
Is it okay now? Same.
Right, I can see that. Perfect. Right. Okay, came back. Right. Okay. Now, yeah. So Right. So when you're talking of control of hemorrhage, you have to always see the bleeding area. That is control of hemorrhage. When you say what you see outside is one, and there are 4 more areas you have to be worried about. So one is the we usually say 1 on the floor and 4 more. So 4 more is 1 in the chest, pelvis, abdomen, the whole of abdomen. Each lung can contain up to about 1.5 liters. Each lung. Tummy can contain the whole blood volume of the person, and pelvis as well. Then the limb compartments. Each limb, a thigh can hold up to about 1 to 1.5 liters. It's a large amount of blood. So you need to look at these areas also, apart from what you can see outside. So control of hemorrhage as well as starting volume replacement, that has to be quite judicious, especially on ongoing bleeder. You should not try to get the blood pressure to normal, because once you try to put in normal saline or heart mask, which are the preferred solutions to be infused, you should not try to get the blood pressure to normal, that is 120 systolic in a actively bleeding person, because you are diluting the clotting factors as well as the blood, and also dislodge any clots that have been formed in the vessels. So that is one thing you have to. That's what we call a high potency resuscitation these days. Right. So once you are happy with circulation, you move on to disability. That means we are talking of the central nervous system. So we have to quickly assess basic we have to assess the neurologic status by assessing his brain function, as well as you use I'll disable my phone. Sorry. One second. I'll just. Sorry about that. I had a call from the hospital. So I'm right now. So you need to check the baseline brain function by using GCS. We used to use AVPU as well. That is with a patient. AVPU means patient is awake, respond to verbal stimuli, respond to P is response to pain and unresponsive. But I think now GCS is widely used to assess the neurological function of the brain. So you need to quickly assess the GCS. Other thing is the pupils you need to look at. Usually the pupils dilate on the same side if there's intracranial space occupant lesions like bleeds happen. So you need to look at the pupil size as well as the reactivity of the pupils, and there is 1 to 8 scale. If that is one side of pupil is dilating, that is the very ominous sign that you need to act very quickly. And also you can assess the peripheral nerves by asking the patient to lift his hands or squeeze your fingers. or lift the legs like that. So you can assess the peripheral nervous system as well. And of course, here also you need to check, if you're not checked up to now, you need to check the glucose level, because that also can have a impact on the function of the nervous system. Then going to the next level is the exposure or the environment. E is for exposure and environment. Exposure is you need to completely undress the patient. Here you have to sort of make sure that you respect the privacy of the patient, and you need to have a chaperone if there's the patient of the opposite sex, and completely expose the patient and look for all the injuries which can be hidden, especially behind the body, the rear side of the body as well. So there could be hidden stab injuries or bruises that can telltale signs of a major injury inside. So we need to completely expose, remove all garments, and have a look. And if you are not done the log rolling, usually it's done here, or it's done at the disability or ABCD level, or if it's not done at D level, you have to do at E, that is at this exposure level. You need to log roll and look for any injuries at the back of the chest, tummy, as well as the limbs. So have to do that to assess the injuries. And also we know when the patient is traumatized and they're hypotensive, they can't maintain their core temperature. So loss of core temperature has a direct bearing on the outcome. So the patients may lose heat without being able to generate heat, and of course if the core temperature falls below certain level, the patient is going to inevitably end up in death. So we make sure, even in Sri Lanka, in a temperate climate, our units are mostly air conditioned, so they are operating at around 18-20 centigrade. We need to make sure, once we have examined, that we cover the patient well and make that body temperature normal. So that is the basic ABCDE. So once you do that, how long would you need to come to ABCDE usually? Half an hour, 1 hour? No, actually it could be done in few minutes, 4 to 5 minutes, if you're done very rapidly and sequentially and focused. Of course, if you need to do some procedure like putting intercostal drainage tube or intubation, it may take longer. But other than that, one person doing it with a nurse should be able to do it in a few minutes. So at the end of the primary survey, you should have a protected and secure airway, and also patients should be having good ventilation and oxygenation, and all the active bleeder points should have been stopped, which can be stopped externally, as you should have started transfusing crystalloids, that is normal saline or Hartmann's, plus started blood resuscitation, and assessment of the neurologic status as well as protection from hypothermia. So these are the endpoints that should be achieved at the end of the ABCDE. So once you've done that, we have to do some few other things which we call adjuncts. That means other helps that you can get to assess the patient once you've done the primary survey. So you keep on have the monitoring, continuously monitoring. When the patient comes, you have to use the monitoring, the pulse oximeter, the ECG, and if you have a capnometer, you can use that. So continuous vital signs should be monitored throughout the stay of the patient in the resuscitation area. And if possible, most of the new trauma centers would do a arterial blood gas analysis, which will give a very good idea of how the oxygenation, because how much oxygen we give from outside, how much breathing support we give from outside is the end goal of oxygenation of the cell. So we would know the pulse oximeter would only give the oxidation of the blood. So we would know the endpoint, that the cell's oxygenation, which the blood gas analysis will give you a good idea of that by the way of the lactate as well as the base XX measurement. There's other adjuncts that modern trauma centers use. ECG I mentioned about. Of course, it's very important to measure urine output, because good urine output means there's good circulatory volume, good circulatory effort, that means good heart function, and of course, good kidney function. The catheter should not be tried if there's blood at the meatus, but other than that, you should you should put a urine catheter and measure the urine output. We talked about the pulse oximeter, and of course, sometimes, especially the patient needs laparotomy, you need to put NG tubes as nasogastric tube as well to decompress the system, GI tract. Keep the patient fasting, very important, and then other diagnostic tools that we can use is radiology. So radiology department, either we can the primary survey has to include 2 X-rays nowadays, 2 mandatory X-rays: the chest X-ray AP and the pelvis AP. The chest X-ray is mandatory in a primary survey, and usually you should not send a patient for X-ray. Rather, the X-ray machine should come to the patient to get the X-ray. It's very dangerous to send a hemodynamically unstable patient to an X-ray unit which is in a far corner of the hospital. So it's ideally, and if the patient is unstable, we should not be doing X-rays, but of course, the patient is stable and all the X-ray machine can come to the unstable patient, then this has to be done. C-spine X-ray, it is debated, because some centers would do the cervical spine lateral X-ray as a part of primary survey, but others will not do, because it cannot exclude ligamentous injuries. Right. Other very important tool used nowadays is the ultrasound machine to do what we call a FAST examination. That means focus assessment in sonography in trauma, FAST. And EFAST, when you say EFAST, you extended FAST, that means you not only look at the abdomen and the heart chill out, also look at the chest. So usually it is done by in National Hospital. There is a separate sonologist or a registrar who does that. But in ideal situation, the person who is attending to the patient should be able to do a FAST and diagnose fluid. We are looking focusedly at free fluid in the abdomen, free fluid in the chest. In the chest, like hemothorax, pneumothorax, and pericardial effusions or blood, and of course the 4 corners of the abdominal cavity. When you come to DPL, diagnostic peritoneal lavage, very limited use nowadays. It used to be very useful in before the CT and the FAST era, where to check for any blood or bowel perforation, where you make a hole just below the umbilicus. It's just like putting one of these holes for laparoscopy you may have seen. So you use a catheter, like a PD catheter, and infuse about 1 liter and get that, keep it for about 10-15 minutes and take it 5-10 minutes and take it out and look at the fluid and then assess how bad is intraperitoneal organs. As I told a while ago, it is less used nowadays because ultrasound and CT has been used without violating the peritoneal cavity. So at the end of the resuscitation, you need to decide whether you are going to keep the patient or you are going to transfer the patient. So you should not delay transfer for diagnostic tests. So example, you have transferring a patient from say Navagamuwa peripheral unit to National Hospital. You should not send the patient on the way to Gampa for a head CT, because of course you are wasting time. You might as well send the patient directly to Colombo Hospital, where the CT is available and it is can be done very quickly. So should not delay for diagnostic tests. And of course, there's time in between, so you need to monitor till the patient leaves your hand, and you can also do a secondary survey by that time. Right. So at the end of the primary survey, what are any questions that you need to ask me? You can send a text message if you want. I don't know whether I can see them. So the primary survey will end once the patient is in acceptable hemodynamic status and been handed over to another team in your same hospital, or patient transferred to a theater or ICU, or patient being transferred out of your hospital. So if preferably before, if the patient is leaving your hospital or leaving your unit, it's always good to do a secondary survey before the patient leaves the trauma bay. Contrast to primary survey, it is not a system based, it's a head-to-toe examination to look for all the other injuries, In primary survey, you look for the life, only immediate life-threatening injuries. If it's a compound fracture which can cause infection and life-threatening injuries later, is picked up at a secondary survey. But if it's a fracture which is close to a femoral, say example, femoral artery which is bleeding profusely, is picked up at the primary survey, because the bleeder can kill very fast. So the same injuries can be picked up either in the primary survey or in the second survey, depending on their impact on life. So in the secondary survey, you look for all the life-threatening injuries, and patients should be hemodynamically stable and normal. There are two different things, stable and normal. The patient can be systolic 90 for more than half an hour, he is stable at 90, but he's not normal. So when the patient is stable and normal hemodynamically, is the time one should be looking at the secondary survey. And also, if you are the only person, this is the time you should be calling your seniors, yelling at them to come and help you, maybe other nursing staff and other paramedical staff to help you out, because this is the time you have a bit of time to get your team organized and get on with the secondary survey. So all major trauma patients should undergo primary and secondary surveys. It's not a patient who comes with a small injury to the small toe or something like that, but all polytrauma patients should undergo primary and secondary survey. You start with asking some history if the patient is able to give a history, or you can ask from bystanders or the whoever who brings the patient what few things. We use the mnemonic ample. Right, use the mnemonic ample. Starting A is for allergies. It's very important to know before administering any antibiotics or any other drugs, because that itself can cause anaphylactic reactions. If you don't know the patient is, for example, allergic to penicillin, the moment you give fluoxetine or something, patient may collapse. So allergic history is very important if you can get that history. Then M stands for medications. So there are lots of medications the patients are on, especially the elderly population. They are on anticoagulants like warfarin, aspirin, clopidogrel, and they can be on beta blockers, which can affect their heart rates. Sometimes the heart rate would not go beyond 100, 110, how bad the hemorrhage is. So you need to know what the medications are. And of course, past illnesses, like they are treated for cardiac diseases, hypertension, diabetes, epilepsy, past surgical history. So everything has been taken at that point, past illnesses. We'll leave the last meal, because as we know, most of these patients may end up in surgery. So you need to know when we can operate. Of course, the patient is very, very unwell, crash in blood pressure. You may take the patient even with a full stomach, but Other than that, you may need, the anesthetist will like to know when the patient started fasting to operate on a empty stomach. So last meal time is important. E, ample. The last letter of ample is E, the events. So whatever events that had happened before the trauma, that means whether the patient was traveling, walking or on a bicycle, push bicycle, motorcycle, what speed, crashed with what, ejected, was trapped for a long time. So all the events and the blood loss at the place, so all events covered with E. So whatever the eyewitnesses, the patient relations, the police, the ambulance crew, they may be able to give some information on this. And again, environment is the same. The environment of in other countries, whether it's a cold environment, whether there's fire around the place. So those all will cover by the E, event of the ample. So this history has to be taken, unlike in a normal case where you take history, past medical history of presenting complaint, history of presenting complaint. That sort of history is not applicable in polytrauma patients. This is the basic necessity, mandatory trauma history that you should be taking in a trauma patient. And also some people add S onto this, that is signs and symptoms after the events, whether the patient had a cardiac arrest, whether they had low blood pressure, or what are the respiratory arrest, or whatever signs and symptoms since the event is also some people add onto ample history. Right. So starting the secondary survey, it's a head-to-toe examination. So starting from the head, you quickly look at the starting from the scalp, look at for scalp injuries, bleeders. Sometimes there's small children can massively exsanguinate from scalp laceration. So look at the scalp, any boggy masses on the scalp, depressions, right? Look, you have to palpate very well through the hair, and look at the forehead for any depressions, any fracture areas. Look supraciliary ridge here, right? Infraciliary ridge. Then look at the maxilla for the movement and upper jaw, and palpate the whole of the lower jaw for any injuries, any broken teeth. Open the mouth and have a look at any injuries to the tongue or throat. Use an oroscope to look at the ear, internal of the ear, and you can look at the behind the ear for a battle sign, and look at the eyes. If you have ophthalmoscope, you can look at any blood in the chambers of the eye, and don't forget that, as I told you in the beginning, the back of the head, the patient may have severe lacerations and fractures there as well. Then coming to the neck, after the examination of the head, coming to the neck, if the patient has a collar, you need to undo the collar by asking someone to stabilize the head. So you undo the collar and look at the neck, look for pulsars, look for any expanding hematomas, any crepitus, and look, palpate the behind the neck for any, if the patient is conscious, any tender areas or any gaps for cervical fractures, and also look for any distended neck veins, which can be a telltale sign of tension pneumothorax or cardiac tamponade. So once you examine the neck, you put the collar back, then you come to the upper, from there you can go to the chest, look at the chest, any observe for entry, observe for bruises, anterior, lateral as well, as far as you can see from the top, and palpate from the tender areas and tender areas which probably will be underlying fractures. And again, you can check for auscultate and check for air entry at the end of it. Percussion again can be used, but sometimes in the fracture it could be fairly painful, so be a bit careful when percussing on a chest, especially if there are injuries. Then coming to the abdomen and pelvis, palpate the abdomen. First look at any bruises. This RIF bruise, it could be a telltale sign of a liver injury. On the left side, it could be underlying splenic injury, and in the loins, it could be a bruise can be a clue for underlying kidney injury. Look for all the telltale signs and then palpate the tummy. So if there is soft or there's guarding or with there is rigidity, and this guarding with this generalized guarding or is a localized, and also auscultate for bowel sounds. If the bowel sounds are there, you may be happy, but nothing can be excluded by the presence of bowel sounds. There could be blood inside, there could be even bowel perforation in the presence of bowel sounds, but at least you listen to it and document it. Then coming to the pelvis, palpate the pelvis. You should, if you are suspecting a pelvic, like open book type of major pelvic injury, you should not be, pressing the pelvis a lot of times. You can just put pressure on the pelvis and look for pelvic stability once. So once that is done, we should not repeatedly do that, especially if there is a suspected or diagnosed pelvic fracture. Sometimes pelvic will be bound with a pelvic binder that is usually done on the circulation part with the ongoing bleeding from the pelvis. So in that case, you should not take it out at this time. Then don't forget about the perineum, rectum, vagina, especially if there are injuries to that area. Look for the perineum. There are injuries, active bleeding, blood at the meatus, testicular injuries, bleeding from the vagina, bleeding from the rectum, especially if you have done the rectal examination during the log roll, you'd be able to look at the sphincter tone, perineal sensations, and the blood and the position of the prostate. So those are things that you look in the perineum. Coming to extremities, you palpate the whole length of starting from upper limbs, each limb, from the shoulder to the tips of the fingers. Look for any bruises, any cuts and injuries, abrasions, lacerations, hematomas, and don't forget to feel for extremity pulses, the radial pulses in the upper limb, and dorsalis pedis and posterior tibial in the lower limb, and the sensations, fingertip sensations as well as lower limb sensations. If there any problem, any fracture or any deformity, you need to gently correct them in a splint. In this time, and also you do a quick neurological assessment. If you have not done previously GCS assessment, you can repeat it at this time, and spinal cord assumed to be done during the log rolling. You can check the sensation and the motor functions of the limb if the patient is conscious. Very important in trauma to document everything, because first thing, it may be the baseline assessment where another person can test later on and see if the patient is deteriorating or not. Secondly, it's very important for medical legal reasons that all in these assessed and documented, because that what you write at that point will stand in any court of law as the real thing that has happened. If you're not written, anyone can say the debate on saying that no, this was didn't happen during this trauma, this could have happened some time back. So to prevent any medical legal disadvantage or undue advantage for the patient, we should always document what we find. Right, pain relief is one of the very important things in end of primary survey as well as secondary survey. So a lot of people are a bit worried of giving opioids to head injury patients, but it's not contraindicated. I think head injury lecture is not included in this, maybe in another time. But of course, if you are the neurosurgeon's surgical team has seen the patient or your assess GCS, and especially the patient had a CT, there's no, and it's normal, there's no contraindication to give opioids like pethidine or morphine to pain relief. So monitoring is essential in all patients as well as patients who are hemodynamically compromised, because once you give opioids, they may stop breathing. So assessment is very important. Right. So which patient should I transfer? Very important question. So you need to know what is the capabilities of your institution, what is the situation of the patient. So quick assessment by you, and if you are the most junior person, get your senior to assess before deciding on a transfer. You have to give the information properly before. Even transferring should be done after contacting the particular hospital, because that is, it will come in the future. Now what happens is most of the peripheral hospitals just push the patient into ambulance, and the patient will, hoping the patient will arrive in the next hospital alive and well, but sometimes it does not happen. So it's very important to contact the receiving hospital. Sometimes, for example, from Navagamuwa, the usual transfer happens to Gampaha, and then the multi-trauma patients will come to Colombo. I'm giving the Navagamuwa example because we get patients from Navagamuwa all the time. So if there's not severe head, no severe head injury, the patient GCS 15, you will send to Gampaha to get a head CT and to assess if there's especially a suspicion of a fracture. But if the patient is low GCS, the patient needs to go to a neurosurgical center rather than a CT place. So you have to assess, you have to use your intelligence to assess what is the condition of the patient and what are the capabilities of the hospital and what's the terrain. So I was working in Nuvareli Hospital. For me to send a patient from Nuvareli to Colombo would take about 6 to 8 hours. So the patient will cone by that time. So I need to think whether I would do a craniotomy at Nuvareli or send, the patient is fit enough to be sent to Kandy or Colombo. So that decision you have to take. So patient's comorbidity, age, and the complexity of the patient injuries has to be taken into account. So when should the transfer occur? Of course, patient should be stable. As I said, hemodynamically stable and near normal, maybe not normal, but you can continue the resuscitation while transferring the patient. Because if the patient is unwell, a doctor has to accompany the patient, as well as a nursing, as well as other paraclinical staff. So you can, if the patient needs laparotomy and your center does not have facilities to operate, the only way to save the life is to transfer. But if you transfer hypotensive patient, you'll be lost on the way. So prevent that, you can adopt transferring while resuscitating. You do resuscitation as much as possible in your place, and then transfer while doing the rest of the resuscitation, including blood and oxygen and intubation, etc. Right. So that is so this is the summary of the whole presentation that, or your lecture that we talked of. You prepare yourself, then attach the patient to monitors, ECG, pulse oximeter, capnometer, BP monitoring, and then carry out the primary survey. You resuscitate if and when you find life-threatening injuries, and use adjuncts to help your diagnosis and treatment. And once you do that, the patient, if you have done it properly, the patient should be stable here, and you have to reevaluate. And once you've done it, doing that, if the patient is stable and hemodynamic parameters becoming normal, then you can decide whether the patient will do a secondary survey and discharge to a relevant facility, or whether the patient needs to be transferred out. So do a head-to-toe examination, especially when the patient is stable before leaving your unit. You leave in the trauma bay before leaving to a ward, because you may miss another life-threatening condition which you are not, or not life-threatening but serious condition, the patient would suffer otherwise. So once end of the second survey, again reevaluate. You use further adjuncts like limb X-rays, further ultrasound scan, duplex, that's and CT scans, etc. And then the patient is at this time stable. Of course, you go to definitive care, like hand over to your own hospital team, ICU, theater, or transfer out of hospital. At any point in these situations, the patient becomes hemodynamically unstable, you go back to primary survey and you have to complete this too. Thank you.
Okay.
Any questions? I think I've eaten into Dr. Sanjeev Senaratne, Professor Senaratne's time.
Sure, no problem.
In a pelvic fracture, how much of blood can the patient roughly lose?
Yeah. I can't unlock it. Take the message, I'll talk later. Hello. Yeah, what is hello? Yeah, what was the question?
In a pelvic fracture, roughly how much of blood can a patient lose?
You can lose the whole blood volume in the body. There's no limit to pelvic bleed or abdominal bleed. It is usually retropelvic bleeding. The pelvic peritoneum will be pushed upwards, but there's no limit. You can exsanguinate from a pelvic fracture. Any other questions? Okay, thank you very much for Sanjeev to giving me the opportunity, and thank you for listening. Hopefully next time we can see face to face and do this lecture, which I usually enjoy doing. Sanjeev will take on from here. Thank you.
Yeah, thanks a lot, Dr. Abhijit. I'll take it from here. Okay, guys, you want a break for a couple of minutes before we start, or are you happy to go like this? Continue.